Hello. Hello. Good afternoon. Am I audible?
Yes, madam.
Hello. Good afternoon, sir.
Good afternoon, madam.
Yes, sir. Good afternoon, sir. Sir, shall we start, sir?
Once again, madam.
Yes, sir. Sure. Good afternoon, students. Good afternoon, sir.
Good afternoon, madam.
I'll share the video, sir.
Yeah, yes, madam.
Yes.
Once again, I extend my warm welcome to the students and lecturers for this program. Now, once again, we are much amused to continue our session on the topic cardiovascular system. Now, we are very much pleased to welcome Dr. G. Gajalakshmi, MSc PhD, who has completed post-graduation in MSc Medical Physiology as a university first rank holder from Dr. ALN PG, IB, MS University of Madras, and PhD in Physiology, Faculty of Medicine. Now, currently, she is working as a professor and HOD in Department of Physiology in Asian Memorial Dental College and Hospital, Chengalpet. She has also acquired degrees in the field of criminology, criminal law, and psychology. She has published various research articles in both national and international journals. She has received many Best Paper awards consequently for more than 5 times in a state conference. She is also a receiver of Best Teacher and Academician awards. Now, we welcome Dr. G. Gajalakshmi to endow us with her knowledge. Welcome, ma'am.
Now you can share your presentation, madam.
Yes, sir. Yes, sir. Thank you. Thank you for that wonderful presentation. Thank you, sir. Thank you, students. So I'm sharing my screen. Hello, sir. Shall I start to share, sir?
Yes, madam. Yes,
it's not audible, sir.
Yeah, now you can share, madam.
Okay. Yes, sir. Sir, my audibility is clear, no, sir?
Yeah, yes, madam. It's audible now.
Yes, sir. Okay, sir. I'm sharing my screen, sir. Sir, the screen is visible, sir.
You need to share, madam. Your presentation is not visible now.
It's not visible, sir. Okay.
Yeah.
Sir, it's asking to share from screen. Sir.
What, madam? Pardon, madam.
Yeah, sir. It's asking screen sharing.
Yeah.
Is this now visible, sir?
Yeah, yes, madam. Yeah, now
Okay,
it's
sir.
visible.
Sure. Yes, sir. Now I can start. Yeah, fine, sir.
Yes.
So a very not even warm, it's very hot, students. Very warm, come hot afternoon. Good afternoon, everybody. I'm Dr. Gajalakshmi, and I'll be delivering a small talk on coronary circulation and pathophysiology of shock. Being first years to speak with, I think from examination point of view, this is a very important question. They'll ask this question as short notes. So from your point of view, this is important. If other dental ears are participating, this is going to be a wonderful topic because it's a clinical topic. And in forthcoming years, this will be really helpful for you to find cases and as practice as a dentist. To start with it, first, why did I make this people with a mask? Many people in our country, they do have cardiac problems. but they wear a mask telling that they are themselves fit, and they go undiagnosed. They don't get properly diagnosed by themselves. And the problem lies behind is they are not aware of the real cardiac problems that is there. Probably we can say that most of the non-medical background people, they are not aware of what are the issues that is there, like in terms of symptoms or in terms of risk factors like that. So this is how this problem starts with. And to bring about awareness, every 29th of September, we do celebrate World Heart Day to bring awareness among our people so that we can save millions of lives. So I think I'm audible. Yes, students?
Yes, madam. Audible, madam.
Okay, sir. So now let me start with the coronary circulation. Why this picture, at the need of the hour? One thing, it's an afternoon. I just wanted you to advise, stop taking more of junk foods, go for more of green, as well as with a lot of fruits, which is going to be good for your heart. Okay. With this, I'll just start my topic. We all know about the heart. Beautiful topic. Just we had our Valentine's Day. And apart from that, to start with our cardiovascular system, I think many professors from morning, they would have given a talk about it. Now, coronary blood flow is around 4.7% of the total cardiac output. Now, suppose your heart doesn't get there. Do you think it will keep pumping? Yeah, it does it. But it is always at the risk of our life. It's something life-threatening. So it is always nice that we should get adequate blood flow to the heart, and the coronary circulation is one such special circulation. When I speak about this, like you have to understand a very basic idea here is the heart pumps blood to all the parts of the body, but when it comes to itself, it gets only during the period of diastole. Now, coming to the coronary blood supply, we have two main arteries called the coronary arteries. We have right coronary artery, the left coronary artery, which are branches of ascending aorta. Now, this right coronary artery is the right ventricle and the right atrium, and we can see the left supplies the left side of the heart. There are no anastomosis. I hope as students, as you are part doing your anatomy, I hope you know that there's no anastomosis. That is the thing. So there are no arteries, and that is why, there will be like the. So we have what is called the place where behind the semilunar valves, we have sinus valvosa, where the eddy currents just develop. And this is one which keeps the away from the wall of the vessel. Make it open. This allows the blood to coronary arteries. So you can see beautifully this picture. I'm showing this picture because I wanted all the students first who are here, please draw diagrams in your physiology exam papers. Should be so many of draw as many diagrams in your examination point. Okay, so here you can see we have the ascending aorta. You can see beautifully emerging the two arteries. We have the left coronary, we have the right coronary, and we have a lot of subdivisions of these arteries that is supplying the substance of the myocardium, the endocardium, as well as the epicardium. Coming to the venous drainage of it, the main system here, it has the coronary sinus and the anterior cardiac veins that drains directly into the right atrium. We all know that superior vena cava and inferior vena cava, they pour the deoxygenated blood into the right atrium. So where do the heart itself drain into the substance of the right atrium? The minor system, we have the aerosinusoidal vessels, the thespian veins, and the arterioluminal vessels. You students might think why this has made some highlights. These are the key points we examiners look when we go for correction, and these points should be there in your paper. Now, coming to the innovation, we have both sympathetic and parasympathetic. As we all know, the sympathetic, okay, it is going to bring about the coronary vasodilatation. Okay, probably the receptor through which it acts are alpha receptors. The parasympathetic is again the vasodilatation. It is again mediated through the cholinergic receptors. Now, this is the most important area that you are many times being asked in your examination. What are the special features of coronary blood flow? Now, you have to know that heart pumps blood to all the parts of the body, but it takes its own blood during the period of the diastole. Usually, I start my class telling that it always starts from the bedside to the bedside. So I always give a example and then make them is a patient them following a bypass, or he is a heart patient. I say, don't do strenuous exercise. Why should we advise them don't do anything strenuously? Because when anybody does something strenuously, your heart rate will increase. Definitely the period of diastole is going to get shortened, and there will be again a compromise in the coronary blood flow. Advise the patients with cardiovascular issues not to do this exercise. So you can see here, it is going to decrease and increase, it is going to decrease during systole and increase during the diastole. So you can see that the cardiac output, okay, probably everywhere, only during systole, the other organs get, but heart gets its own blood supply only during the period of diastole. So it's something like once when there is going to be systole, what happens, those coronary vessels just get compressed, and you can see particularly in the subendocardial layers. Only during diastole, all these relaxation do occur, and that increases the coronary blood flow. The coronary arteries are end arteries, so there is no overlapping. So that is why when there is a block, there is issues of ischemia or infarction. I think I'm audible and you're able to see my screen as I'm scrolling, and you're all able to follow, right?
Yes, madam. Audible, madam.
Yes, yes, sir. So coming to this coronary blood flow, like you can see that it's get adjusted to the metabolic needs of the body. Suppose, for example, if there's going to be more amount of potassium ion accumulation, or there is lactate getting accumulated, definitely depending on the needs, coronary blood flow do get adjusted. Now, just 3 points I said. Students, do you think like you need to memorize them? It's anybody you tell them, they just take up it. Only during diastole, it's going to receive. There are no end arteries. And third point I said is getting adjusted to metabolic needs. I hope you have 3 points in your hands when you get a question on this. To coronary blood flow, like it gets 4 to 5 folds. Suppose I ask you all to just take a marathon and you just make a move. Definitely, your heart has to pump to the exercising muscles in everywhere. So definitely there's going to be more oxygen needed, and that adequate blood flow reserve is always there. Then the heart utilizes everything. It's so sweet, that's why we say, heart, something with do it. It you use a wide varieties of substrate, not like our brain, which says that I want. It's very fuzzy. And heart, something so sweet. So it includes all the free fatty acids, glucose, lactate, and amino acids. So it's around like main source of from the fatty acids. That's why when I tell some of my patients also, never go for a strict nil fat. So your heart is going to expect around 80% of the oxygen from the arterial blood. And as more oxygen is required, as there's going to be an increase in the coronary blood flow. So looking to the value of your heart is to be a sign of, I think all these intro, the senior professors who came earlier would have told. But you can see that it's around 250 ml per minute. So please don't write liters, don't write centimeters. Please, this is where you show that you are somewhere out of stream students. It's just 250 ml per minute, or somewhere around 85 ml per 100 gram of cardiac output per minute. So this rate of cardiac flow, no, it's second highest, okay, second highest to the renal blood flow. And coronary blood flow, it accounts 4.7% of the total cardiac output. And more oxygen consumption, definitely its highest is the heart, which takes around 9.7 ml per 100 gram of tissue. Now the students will ask a question, ma'am, we are max phobia, numerophobia. We don't want numbers. We don't want numbers, yes, honestly, but write those points in the exam so that the examiner will feel happy to fetch you marks. Coming to the measurement of coronary blood flow, we have, there are basic two methods like direct or indirect method. The direct method, like we put an electromagnetic flow meter in coronary artery, okay, and that measures like where you can do following open heart surgery. And expert sir, Purushothaman sir is there, where he would have given you more idea about biophysics of electromagnetic flow meters. Coming on to this indirect method, we have fixed method and radionuclide method. Fixed principle, if for once, can apply for all the special circulation. Just look into it. It's very simple. You take, okay, and you're going to take, for example, a subject, he wants to know how much is the coronary blood flow. You're going to give him a mixture of gas and an inert gas like nitrous oxide. Don't think like some carbon monoxide. All those things only write in the exam. It's something useful gas, okay? We give nitrous oxide and you're going to just allow it to distribute to the tissues. Now, what is that you're going to calculate? You're going to see the amount of that inert gas that is taken up per minute by the AV difference, that is artery venous difference of that gas. That will give the idea about coronary blood flow per unit time that has been there. The radionucleotide, like as we know, the radionucleoactions like thallium, we just inject IV. The gamma to monitor. We use radioactive xenon also. So all these will give you an exact idea about the blood flow, the coronary blood flow. Now coming to the regulation, it's very simple. Like always, it'll have a neural and a hormonal regulation to bring about homeostasis. So when it comes to neural regulation, okay, you have the sympathetic the when you are tense, like sitting in an anatomy class, I hope no anatomists are here, or when you are sitting in some dental where you get tensed and blasting and all. But when you come cool, no, when you come to physiology, right? You have. So parasympathetic is where you are cool, physiology. Sympathetic layer where you're at home or where you're in some dental way, or whatever. So when sympathetic stimulation produces, there is going to be vasodilatation, there's going to be increase in your what you call the coronary circulation, and there's going to be vasodilatation, partly because of the metabolites that does. Okay, but parasympathetic, even it does cause, but there is very sparse, not like the sympathetic. Coming to the metabolic regulation, we have the auto regulation facility, so it does beautifully. So a close relationship will be there between coronary blood flow and oxygen consumption. So there are a lot of metabolic factors, that will bring about this coronary vasodilatation, like hypoxia, carbon dioxide, when there's more of lactate, which I told already, like adenine nucleotide. These substances immediately, they bring about metabolic regulation. They try to enhance the blood flow, okay? They does a very beautiful job there. So auto regulation, which I said, they know to regulate. See, when there is any problem, we immediately run here and there. See, most of our organs are designed in such a way, they have their own regulation. Only when they feel they just give us symptoms. So the auto-regulatory mechanism here is a normal when it comes to the pressure of 70 to 10 mm of Hg. And there are a lot of physical factors also. See, the blood flow to cardiac muscle is totally dependent on the myocardial tension. So that is where that pressure that builds during your muscle contraction. So the primary factor is determining the coronary perfusion is the physical factor like vasocompression and all that. So this diagram we expect you all to do in your exams. Okay. What is this diagram shows about? Always make an X and Y axis. They show you there about the coronary blood flow, and they wanted you to show it in times. You can see in the first chart, they're showing you the systole and the diastole phase, like how is the blood flow in the left coronary and the right coronary artery. Parallelly, they want to show how is the aortic pressure. As aortic pressure increases, because during yes, the blood pumps to all the parts. So you can see that there is a decrease in the coronary blood flow during the systole. But what happens during diastole? There is increase in the coronary blood flow during diastole. So such a type of blood flow is what we call basic blood flow, which happens only in the coronary artery. Okay, I hope you all understood. Shall I proceed to the clinical relevance of it? Now coming to coronary heart disease, probably this coronary blood flow with a lot of regulations, with a lot of things which has been blessed by our nature or God. But what is happening? Yes, definitely because of all our habits, it happens that there is a decreased blood flow to of myocardial ischemia. what is ischemia? Reduced blood flow to the heart. Yes, there is a reduced blood flow to the heart. Probably, just 1 minute. Okay, there's a, okay, sorry. Probably because there's a myocardial ischemia, probably because of angina factors. This myocardial ischemia is what is that? It's because there's a decreased blood flow. There is a decreased blood flow. Probably that's what we call ischemia. So the patient, when they experience a chest pain, we call that as angina pectoris. See, when I say myocardial ischemia, avlo lesila illa. The pain is something like I have seen patients telling me, elephant மேல உட்கார்ந்த மாதிரி இருக்கு. It's something a very new pain, right? The patient couldn't tolerate at all. So it will be like that. So if it is going to be very severe and get massive attack, the myocardial infarction. So probably that could be because of, you can see those yellow ones which is getting deposited nicely. Yeah, that's because of the coronary atherosclerosis. So it starts first with basic angina. You know, our people, no, they just ignore, they don't bother. So what happens at one point when it gets just accumulated, they come with a very massive attack. And again, it falls in the heads of the cardiologists and the cardio technicians to rescue and save the life of the patient. So here you can see the known factors. I hope all must be knowing about it. Say probably if they are more than age 40. But I say now, even I have nowadays coming with cases 30 plus also. Gender males are more susceptible. Okay. Because we females, no, we went off, we cry, we just like that, we know how to vent off our emotions. Men are men, they never do that. So they are in the more higher risk end. Family history, smoking, hypertension, more of cholesterol, diabetes, and other hemostatic instability issues. When we go for a more of sedentary lifestyle, probably because of this pandemic, I think all of us, past 2 years, we have been more sedentary. Obesity, alcoholism, homocystinemia, stress, everybody. You ask, even a first standard kid is saying that she is stressed. Stress into it. So next, coming off angina, I hope you all know it's a chest pain, where because of there's no blood flow properly to the cardiac muscle. So mostly here the patient comes with a complaint on the pain in the chest, but usually they say complaint on the left side of the shoulder and left side of the arm, sometimes radiating to the jaw and back and all that. Probably the pain is because of the accumulation of the P factor. And you can see it has got a characteristic way of radiating. So again, this point is very important. I think you can correlate with when you read referred pain also. This is one of the best example you can write, the dermatomal rule. That example itself you can write. So it's a bonanza. If you read one, you can correlate. That's how you should read physiology. Physiology is full of concepts. With the love and affection, if you read, no, you can very well score good marks in your examination. Next, coming for this myocardial infarction, my God, 75% is total closure of the lumen. No blood flow, complete loss of this blood flow. So what is going to happen? There's no blood. So there's spasm of the coronary artery. The platelets, they just get aggregated. And you can see that sometimes they even form a big plaque, or sometimes a rupture of the wall. And that results in what you call a very massive attack. Okay, probably it goes painless in people with diabetes. Next, coming for the diagnosis, yes, the ECG, a boon, right? It's like a window where you view your heart. So the typical changes will be the thinking that you know the waves and explaining the elevation of the T segment, okay, and sometimes you can see the inversion of the T waves. The biochemical test that we do will be increase in the creatinine kinase and lactate dehydrogenase enzymes. These are key factors will help diagnose the patient that the patient gives to us, and immediately we put the patient on coronary angio. Like we pass the we inject it with a dye and we study all the contours and anatomy and we find where is exact obstruction. Just look into this picture, okay, you see the left side of it, right? But you can very well make it here that there's an obstruction, right? So this is the right and the left, like we get the pictures, and if there's any obstruction, then we plan for the further part, like say we mostly go for, if second year are they be helpful, like I'm discussing pharmacology, like we go to Vasodilators. I hope you would have heard of the reduce the preload and afterload. And streptokinase is a drug, like immediately we give the thrombolytic injection when the patient comes with such an issue. So it will try to cause the fibrinolysis. And here you can see the coronary angioplasty where we insert a balloon and then follow it with a catheter. A balloon will be there that will inflate it. We go placing also. We give calcium blockers that causes coronary aspiration, and we give aspirin that's which will inhibit the platelet aggregation. Now here as a dentist, everybody who are here in the meeting, please understand, when these people are inhibiting the platelet aggregation, okay, if you find any people in future, if they are heart patients, kindly note down what are the drugs that they are taking before you go up for any dental treatment. Suppose if they are on blood thinners and you are going to just pull the teeth, these people will die because of bleeding only. So be cautious, be careful. That is, you might think like, what is this? Why should I sit in this afternoon, listen to all these stories? At the end of it, happen. So you have to be very cautious when you're going to touch. And apart from that, we give folic acid and vitamin B12. Probably that is going to help in removing out the toxic compounds. And surgical, like you can look here, the coronary artery bypass grafting. And apart from that, we also do placing a stent. Okay, and we just speak like this, but when it comes to rehabilitation of these patients, it is something very tough. And probably the next is like if we work as a team. That's why we have to work as a team, then only. So when they come to you with some dental intervention, you have to seek opinion of the cardiologist and or the cardiac surgeon, and then you have to proceed. So when it goes in, you will be able to hope till here the coronary part of it is fine. And just moving on to another interesting area, the pathophysiology of shock. முதல்ல புரிஞ்சுக்கோங்க, ஷாக்னா நான் கரண்ட்ல அடிச்சு விடுற ஷாக் சொல்லல. This is something different. It is the pathophysiology. Everybody will hear the word shock. What is shock? It's nothing but there's an inadequate tissue perfusion, but there can be or may not be a cardiac decrease in the cardiac output. Okay, but tissue is not getting enough blood flow. This will happen particularly in we give you some work, like in the lab for so many hours, like you go direct to the mother earth, you fall flat onto the ground. I didn't drink anything, I didn't do anything. What is that? It's like a form of hypotension. But when it becomes very severe, you go for a hypovolemic shock. So there's an inadequate cardiac output because of decreased volume of fluid in the vascular system. Probably see there could be an hemorrhage or some injury that brings about a traumatic shock. Sometimes in surgery, particularly postpartum after the delivery, and burns, or there is some disease. So that we have another type of shock, see, distributive shock. Here what happens, there is because that honey bee sting or the the tail கொட்டுறது இதெல்லாம் இருக்கு, anaphylaxis. It goes for anaphylaxis because it's notorious spell in our body, histamine. Okay, because of these basophils mast cells, they release them, they create big havoc in our body. So you can see that suddenly the blood pressure will decrease, it will be marked. Sometimes it can be because of neurogenic shock. Like what we call, like in movies and all, they'll show somebody will read a letter, so something like that. Okay, and or you could have seen, like probably because of some septicemia, they go for a septic shock, or there is severe myocardial contamination and there is a lot of infection because of this gram-negative bacteria, endotoxic shock. We have cardiogenic shock because the heart is not enough to pump blood. Like when a person is having acute myocardial infarction or there's heart failure, they die. There's a shock because there's no blood flow, because there's some reason behind. There's some obstruction to the blood flow from the ventricle. Like it can be because pericarditis or tumor or pneumothorax, anything like that. So what is happening? So in detail, I'll explain about hypovolemic shock. I hope you understood about shock kinds of shock. But I'm going to talk only about the hypovolemic shock, because that's more common that we see in our clinical practice. Even in future, you might, because of some severe pain, So it is common of all shock. The common form of hypovolemic shock is hemorrhagic, traumatic, surgical, like that. So here you can see that the person immediately, they have hypotension, they'll have tachycardia. Sometimes you will not be able to feel the pulse. It will be very pretty rapid. And they'll be very cold, pale skin, tachypnea, they'll have thirst, they'll be conscious, but they'll not be able to respond to you, right? You would have come across this. So there are many stages, like we have to be very cautious. I think I'm audible and I'm going in right pace. Am I right, sir? The screen is visible. Is it fine, sir? Hello, sir? Hello?
Yes, madam.
Yes, sir. It's fine, right, sir? What I'm doing is right, fine, audible. Everything is fine?
Yes, madam. Little disturbance is coming.
Yes, sir.
Our
Now, sir?
range illa.
Okay, sir, but I am sitting, I have taken up the near that computer net room only. I took their net and I'm doing it from the. Okay, sir. I think
Audible,
I'm
madam.
audible. It's audible.
Yeah,
Thank you.
yes, madam. Audible.
Okay.
Yeah, thank you.
So shock, as you see, we have reversible stage and irreversible stage. First, in irreversible stage, there will be more of compensatory mechanism. Suppose you're in a distress, your friends comes to help in our body. We have a lot of systems. They come for pushing up and pulling up things. So we have compensatory in form of short term, long term. I hope rapid compensatory will be neural, vascular, even though hormones do participate. So we have the tremendous one comes in the terms of fight, flight, right reaction, the sympathetic system. Then we have the Baro receptors coming up, making a way. And in very severe, we have this Chemoreflex and Cushing reflex. Again, students, BP regulation, very important. You have to know all these regulatory mechanisms when a question is asked as an essay. Coming here for this, the next we have tachycardia. So immediately by sympathetic activation, that will increase the heart rate. Vasoconstriction will be there. That's because of the activation of the sympathetic system, because it is now pulling the blood to all, mainly to the brain and the coronary arteries, and trying to bring about vasoconstriction to other areas, particularly renal vasoconstriction and all that. Now the venous return will try to increase because of the sympathetic stimulation. So there will be more hyperventilation because the thorax starts to pump, and there will be more of increase in venous return. And because of the pumping, the skeletal muscles, as they are very active, they also increase the venous return. Then we have the capillary fluid shift, which is an intermediate way of regulating the blood pressure. So there will be immediate shifting of, because of the pressure gradient, the fluid will shift from the interstitial space into the capillary. So there will be increase in the blood volume. Again, it increases the venous return. So there will be activation of the chemoreceptor reflex if hypoxia or any other issues is placed there. Then we have in very severe, if it's going to be less than 40 mm of Hg, definitely there will be cerebral hypoxia. There will be severe vasoconstriction, and it will be like a do or die situation. And there will be more secretion of catecholamines, probably the adrenaline and noradrenaline, to rescue the situation, because they have to maintain the cardiac output and at the same time maintain the blood pressure also. So the catecholamines, they also stimulate the reticular activating system to make the patient remain conscious and restlessness. Then comes the secretion of ADH, because ADH will stop input and because of this, the blood volume will try to increase. Vasopressin in higher doses also will increase the blood pressure. So the cortisol as a whole, it's an anti-stressor, and it has got admissive effect for the action of catecholamines, so their secretion will be increased. Then there's an activation of renin-angiotensin system. I hope you all know. When renin-angiotensin system comes into play, there'll be more of sodium retention, more of water volume, blood volume increases. So that will try to increase your cardiac output. So you can see that more aldosterone secretion, more sodium water reabsorption. So there will be increase in your blood volume, which in turn will increase the venous return and cardiac output. That will try to restore back your volume into normal. A long-term compensatory will be like increase in synthesis of erythropoietin and plasma protein, because they have to increase the volume, the cellular part of, take even 2 to 6 weeks, probably following up an accident or injury like that. And there is increase in the plasma protein synthesis also, which will take within 2 to 4 days particularly the hemoglobin synthesis that will occur. The irreversible will come into when the compensatory mechanisms fail, when there is very severe bleeding, when there is no medical restoration done. So the cardiac output blood pressure will decrease. They go for a refractory shock or irreversible shock. Even at that moment when you're not going to go for a medical intervention, definitely the person will die. Okay. So any doubts with this? So whenever I start my talk, I always like Dr. Abdul Kalamji. Duty is not behavior. People will always notice the change in your attitude towards them, but they will never notice it's their behavior that made you change. So I would like to thank Dr. Purushothaman sir for giving me this opportunity to deliver the guest talk on coronary circulation as well as shock from the examination come the dentist perspective. So I would like to thank sir for it.
Thank you, madam. Thank you for the wonderful presentation, madam. And
Thank you,
thank you for spending time with us for this presentation, madam.
Thank you, sir.
And thank you so much, madam.
Thank you, sir.
Any doubts? Yeah, yes, ma'am. Please share.
I wish the students all the very best. One thing I would like to share: a good physiologist will be a good physician. Okay, so think about that and start reading physiology, because that is going to be your backbone when you start your practicing. Maybe you may not be known. Been in this field for past 15-20 years, it's my advice, like when students go for their postgraduate exams or when they apply abroad exams, like physiology is one of the mandatory area that you've been questioned. So please see to that you concentrate and do your exams well, right? And during our period, we didn't have such revision and all that. Thanks for sir for making such attempts, so that he is giving you a platform to give you a good revision from different sources. So this itself, you're blessed, and all the very best students. And I would like to appreciate the effort that is being taken by our sir Purushothaman sir. Thank you, sir. It's a wonderful idea. Thank you. Thank you, sir. Thank you, sir. Any doubts?
Any doubts? Students can post your questions in the chat box, or even you can ask to the madam directly. Is there any doubt from the student side? No other questions. Okay, thank you, madam. Thank you for being with us for this presentation, madam. This lecture series will not be ending today. It will be continued in future also. We'll see, madam. We'll be waiting for you to come to our college to present lively to our students also.
Yes, sir. Definitely, sir. It's my pleasure. Thank you, sir.
Yes, madam. Thank you, madam.
Thank you, sir. Thank you, sir.
Yeah, yes, ma'am.
Thank you.
And next presentation is by Dr. G. Satyanarayanan, sir. Sir is going to present the topic on blood pressure and some clinical aspects relevant to the blood pressure. First, we'll see the introduction of our last speaker, Dr. G. Satyanarayana. One second.
Now it's time to welcome Dr. G. Satyanarayanan, MSc, PhD, who has worked on specialization of stress and reproductive physiology. His achievements are remarkable and goes on. He has participated in panel discussion on role of library during the COVID-19 pandemic, and he has also organized National Conference of Physiologists of Institute of Basic Medical Sciences at the Department of Physiology. He has also received Professor N. Padmanabhan Award from Indian Association of Biomedical Scientists during the year 2008. He is a life member in Indian Association of Biomedical Scientists and also a life member in Association of Physiologists of Tamil Nadu. He has carried on with 3 projects and 19 publications. Now it's time to welcome Dr. G. Satyanarayanan to give a presentation on blood pressure. Welcome, sir.
Thank you very much for that introduction. So is it audible?
Yes, sir. Audible, sir.
Fine, thank you.
Now you can share your presentation, sir.
So first of all, I would like to thank Dr. Purushothaman sir for giving me this opportunity, and also for organizing such a wonderful lecture.
Lecture
I think
series.
all the credit goes to him and his team. Okay, thank you.
Thank you,
And
sir.
today we will be seeing about blood pressure and its regulation. So as you all know, if the basis for this blood pressure is smooth muscle, because we are going to see about this blood pressure regulation, which is going to be happening in the blood vessels. So the basis for this is the blood is the muscle tone. So as you all know, when there is a muscle, it should have a tone. Though it may be a skeletal muscle or a cardiac muscle or a smooth muscle, it should have a tone. And for this, the tone of the smooth muscle, that is a blood vessel, it is mainly controlled by either by vasoconstriction or by vasodilatation. If there is vasoconstriction, you can say that the vascular tone is increased. And if there is vasodilatation, which means the dilatation of the blood vessel, vasoconstriction means constriction of the blood vessels. So vasodilatation means the tone is decreased, and vasoconstriction means the tone is increased. So we will be using these two terms so in our future classes now. Okay. So physiological aspects, if you see, blood pressure, it is usually defined as a lateral pressure exerted by the moving column of blood on the contained blood vessels. So you can see from this picture here, so as when the blood is flowing through the blood vessels, how much pressure it is exerting on the wall of the arteries. That you call it as the blood pressure. So once again, I will say this. It is a lateral pressure exerted by the moving column of blood in the contained blood vessels. So when the blood is flowing, how much of pressure it is applying on the wall of the arteries. And this is actually, this one forms the basis for the recording of the BP. So because in recording of blood pressure, you will be recording the lateral pressure, that is using a sphygmomanometer. Okay. So you have two types of blood pressures. One is systolic blood pressure and the other one is the diastolic blood pressure. The systole, as it means that it is contraction. A diastole, it is relaxation. So the maximum pressure recorded during the cardiac cycle is called as systolic blood pressure. And the minimum pressure recorded during the cardiac cycle is termed as a diastolic blood pressure. So morning, I also listened to that cardiac cycle presentation. It was a nice one. I think students, you can able to recall what the morning session was. So about the systole and the diastole. Okay. So normal systolic blood pressure is about 100 to 119 millimeter of mercury in adults. So anything which is above this 120 to 140, you call it as pre-hypertensive stage, and 140 or above, you call it as the hypertension. So the range, so systolic pressure above 120, they are in the pre-hypertension state, and above 140, they are in the hypertension. And diastolic pressure, normal range is about 60 to 79 mm of Hg, and 80 to 90, you call it as pre-hypertensive stage, and 90 mm of Hg, more than 90, you call it as a hypertension. When coming to the systolic and diastole, we are more concerned about the diastolic blood pressure, because this diastolic blood pressure is going to determine the workload of the heart. So if diastolic blood pressure is increased, the workload of the heart will also get increased. And also systolic blood pressure usually varies depending upon the diurnal variation, and also upon the and also depends upon the mood of an individual, whereas the diastolic doesn't change much. So we are very much concerned about this diastolic blood pressure. And the other term, the pulse pressure, which is defined as the difference between systolic and diastolic blood pressure. So it is, the range is about 20 to 50 millimeter of mercury. And the significance of this pressure is it is going to maintain the pulsatile nature of the blood flow. And this pressure is required for the perfusion of the tissues. Perfusion means blood supply. And this is the pressure which is going to push the blood towards the arteries and also perfuse the tissues. The other one is the mean arterial pressure. It is average pressure that is recorded during the cardiac cycle. So this pressure is usually denoted as diastolic pressure plus 1/3 of pulse pressure. So actually it is called as a mean arterial pressure. Actually, we don't take the mean of systolic and diastolic blood pressure here. Instead, we use this formula, that is diastolic pressure 1 plus 1/3 of pulse pressure. The reason is when you would have seen the morning session, the duration of the cardiac cycle. Systole is about 0.1 second and diastole is about 0.7 seconds in atria, and in ventricle it is 0.3 second in systole, and ventricular diastole is 0.5 seconds. So diastolic pressure is the maximum. The heart is exposed to the diastolic pressure for a longer duration. That is the reason why we take this diastolic pressure for calculating the mean arterial pressure. The normal value is about 75 to 105 mm of Hg. And this is also the main significance of this pressure is it also helps in the forward movement of the blood in the vessels and also needed for the perfusion of the tissues. So if there is any alteration, the pulse pressure or the mean arterial pressure, it naturally affects the perfusion of the tissues. So factors affecting blood pressure. The blood pressure is the two main factors which determine the blood pressure are cardiac output and the peripheral resistance. So two new terms. Cardiac output. It is usually defined as the amount of blood ejected by the ventricle per minute. How much amount of blood the heart is pumping per minute, you call it as a cardiac output. And peripheral resistance, the vessels, that is the arterioles, they are called as the seat of peripheral resistance, and these both are going to determine the blood pressure. If peripheral resistance is very high, that is, if the arterioles are going for vasoconstriction, your blood pressure will get increased. If arterioles are going for dilatation, the blood pressure will be decreased. So the cardiac output alteration mainly affects the systolic pressure, and the peripheral resistance mainly affects the diastolic pressure. Because any change in the peripheral resistance, there will be occlusion of the arterioles or constriction of the arterioles. So the blood cannot flow easily from the arterioles to the veins. Naturally, the result is increased in the blood pressure, which will be reflected on the heart. So thereby it increases the pressure to the heart. So now we'll see what are the factors that determine the cardiac output. So cardiac output is defined as calculated as stroke volume into heart rate. Stroke volume, which means that the amount of blood ejected by the heart per beat. It is about 70 ml. And heart rate. So the cardiac output is mainly determined by the stroke volume and the heart rate. Stroke volume is affected by the preload, afterload, and myocardial contractility, and the heart rate is mainly affected by the autonomic influences. So preload. So what it actually means is it is actually determining the end diastolic volume. So end diastolic volume of the heart is going to determine the preload of the heart. The amount of blood that is present in the ventricle is going to determine the stroke volume. And coming to the peripheral resistance, diameter of the blood vessels and the viscosity, these two are the main factors which control the peripheral resistance. When the diameter of the blood vessel is decreased, which means that the peripheral resistance is increased. When the diameter of the blood vessel is increased, the peripheral resistance is decreased. And viscosity of the blood, when it is increased, the flow will be sluggish and thereby it increases the blood pressure. So these are the two main contributing factors for blood pressure. Then we'll see about the variations. So we all don't have a common blood pressure from a childhood to the elder age. So in children, the systolic pressure is from about 120 to 90 to 120, the range. And diastolic, it range from 50 to 80 millimeter of mercury. Whereas in adults, it is about, the systolic is about 100 to 119 and diastolic from 60 to 89 or 60. Okay. In elderly, in old age, the upper limit of systole is considered to be 140 millimeter of mercury. So as the age progresses, there is increase in the blood pressure, mainly due to the loss of elasticity of the blood vessels. You call the condition as the atherosclerosis. So as the age progresses, the arteries, they lose the elasticity and thereby the blood pressure is increased. And gender, the next factor which variation. So male has a higher BP when compared to the females. Particularly before menopause. So the estrogen and progesterone, and they prevent the increase in the blood pressure in the female. That is the reason why male has a higher blood pressure than females, and males are more prone for hypertension than females. And eating. So after a meal, the blood pressure will be increased. During sleep, there is decrease in the blood pressure. Upon emotion and excitement, there will be increase in the blood pressure. So when we are happy or when we are in a sorrow, there is the increase in the blood pressure. And exercise, that depends upon the type of exercise that we do. Moderate exercise, there is increase in the systolic blood pressure and no change in the diastolic blood pressure. When you go for a severe exercise, that is a moderate to severe exercise, you can see the systolic pressure will get increased due to the vasoconstriction, and the diastolic pressure will be decreased due to vasodilatation that occurs in the skeletal muscle. Okay, because the blood vessel in all part of the body will not be responding same to the sympathetic stimulation. So sympathetic stimulation usually causes vasoconstriction all over the body, whereas it causes vasodilatation in the skeletal. So during exercise, that's what happening. So there will be vasoconstriction all over the body, where you have increase in the blood pressure, where increase in the systolic blood pressure, whereas due to the vasodilatation of the skeletal muscle, you have decrease in the diastolic pressure. And posture, when you are lying down, there is increase in blood pressure. When you stand up, there is decrease in the blood pressure. Temperature, increase in temperature will increase the blood pressure. And also pregnancy, there will be increase in the systolic pressure during pregnancy. So these are some of the physiological variations that you see in blood pressure. So then coming to the important part of our topic today, that is regulation of blood pressure. So blood pressure is usually regulated by three ways: short-term, intermediate, and long-term regulation. So short-term regulation means that any change in the blood pressure will be corrected within seconds. So you call it as the short-term regulation. Within minutes to within a day, you call it as intermediate regulation. Within a week, you call it as long-term regulation. Is it audible?
Yes, sir. Audible, sir.
Okay. Yeah. Okay. Thank you. So the short-term regulation of the blood pressure, it usually is related to the neural mechanism. So sympathetic and parasympathetic control. So as you all know, sympathetic stimulation will get activated when there is a fight or flight reaction. Either you have to fight or you have to run away. So during that situation, sympathetic stimulation will get activated. So the sympathetic stimulation mainly controls the blood pressure because the neural input to the blood vessel is mainly through the autonomic fibers, that is the sympathetic nerve fibers. So whatever may be the mechanism, the input that is going to be that is reaching the blood vessel is through the sympathetic outflow. So sympathetic vasoconstrictor system will cause the constriction of the blood vessels immediately if there is a fall in the blood pressure. When the blood pressure falls, the sympathetic the mic is on. Yeah. So the sympathetic vasoconstrictor system will get activated and causes a constriction of the blood vessels. Thereby, it will increase the blood pressure. And also, the sympathetic fibers, they also cause venoconstriction, that is the constriction of the veins. Thereby, it will increase the venous return to the heart. If the venous return increases, the cardiac output increases, thereby it increases the blood pressure. So two ways the sympathetic system can increase the blood pressure. One is through the vasoconstrictor mechanism which acts on the arterioles. The other one is the venoconstrictor mechanism which is going to increase the venous return, thereby increase the cardiac output and thereby increases the blood pressure. And next one is the sympathetic vasodilator system. And this system causes dilatation of the blood vessels. So thereby decreasing the blood pressure. So when the blood pressure is less, vasoconstrictor system and the venoconstriction system will get activated. And when the blood pressure is increased, the vasodilated system will get activated. And parasympathetic control, and keep in mind that there is no parasympathetic fiber supplied to the blood vessels. This is the important point to remember here, because sympathetic system directly innervates a blood vessel, whereas the parasympathetic doesn't have any nerve supplied to the blood vessels. So parasympathetic stimulation or stimulation of the parasympathetic fibers will not have any change in the blood vessel. But we usually used to say parasympathetic stimulation causes decrease in the heart rate and cardiac output. It is mainly due to the vagal stimulation of the heart. So vagus is the major parasympathetic nerve. Vagus is called as the brake to the heart. Vagal stimulation slows down the heart. So when the parasympathetic system is activated, it decreases the heart rate and cardiac output. Thereby, it decreases the blood pressure. So it doesn't have any job to do with the blood vessels. So this is just to show the sympathetic vasoconstrictor system. The sympathetic vasoconstrictor system, wait a minute. So they mainly originate from the lateral horn of the spinal cord. You can see here. It innervates the adrenal medulla to secrete adrenaline. And it also supplies the blood vessel to cause vasoconstriction and acts on the heart to increase the heart rate and the cardiac force of contractility of the heart. So thereby the sympathetic vasoconstrictor system, when it gets activated, it increases or stimulates cardiostimulatory. And sympathetic vasodilator system, the fibers that originate from the cortex and they relay in hypothalamus, midbrain, and after reaching the spinal cord, they come out to the lateral horn and they cause dilatation of the blood vessels, particularly the skeletal muscle. So two systems are the sympathetic vasoconstrictor system and sympathetic vasodilator system. And then coming to the medullary control. So cardiovascular center, it is located mainly in the medulla. So you have vasomotor center, also called as the cardio-axillary center, and cardio-inhibitory centers. These two centers are present in the medulla. So the vasomotor centers, it directly project to the intermediate or lateral horn of the spinal cord, where the sympathetic vasoconstrictor fibers originate, as we have seen in the previous slide. You can see here. So this is the lateral horn. So the fiber from the medulla, that is the vasomotor center, they reach the lateral horn of the spinal cord, where the sympathetic fibers comes out. So the basic tone of the smooth muscles of the blood vessel is due to the sympathetic discharge or due to the vasomotor center. The tone of the blood vessel is mainly due to this impulse that is coming from the vasomotor center, that is the vasomotor neurons. So stimulation of this vasomotor center activates the sympathetic fibers that comes from the lateral horn and causes vasoconstriction and cardio acceleration, that is increases the heart rate and force of contractility of the heart, and thereby it increases the blood pressure. And inhibition of this center causes vasodilatation and cardio inhibition. So activation of vasomotor center is cardio-excitatory, that is, it increases the blood pressure, whereas inhibition of the vasomotor center causes vasodilatation and cardio inhibition, that decreases the blood pressure. So cardio inhibitory center, it is also present in the medulla, and it is formed by the nucleus of tractus solitarius and nucleus ambiguus and dorsal motor nucleus of vagus. They are present in the medulla. So stimulation of these center causes bradycardia, that is decrease in the heart rate, and thereby decreases the cardiac output. So stimulation actually causes the vagal activity, that is it decreases the heart rate and also decreases the sympathetic activity, which in turn causes vasodilatation and decreases the blood pressure. And one thing you should keep in mind that increase in the blood pressure upon sympathetic stimulation is the blood pressure increase upon sympathetic stimulation is mainly due to the vasoconstrictor fibers, and the decrease in blood pressure upon parasympathetic stimulation is mainly due to the withdrawal of the sympathetic tone. So when the sympathetic system is activated, there is increase in blood pressure. When the parasympathetic system is activated, there is decrease in the blood pressure. It is mainly due to the vagus, that is a cardio inhibitory nature, and also due to the withdrawal of the sympathetic tone. And again, this is the picture to show the vasomotor center, the cardio inhibitory centers which are present in the medulla. And then hypothalamic control, hypothalamus. So we have many nucleus in hypothalamus, and stimulation of the anterior hypothalamus, it produces hypotension and bradycardia, and stimulation of the posterolateral nucleus of hypothalamus produces hypertension and tachycardia. So apart from performing the major vegetative functions of the body, hypothalamus also controls the blood pressure mainly by the anterior hypothalamus and also by the post-stimulation of the posterolateral part of the hypothalamus. And cortical control, you can see the cortex does not directly influence the blood pressure, but you can see in the sympathetic vasodilator system. So activation of the sympathetic vasodilator system mainly from the frontal cortex causes the vasodilatation, and stimulation of the motor and premotor cortex usually increases the blood pressure. So cortex has both the functions of increasing the blood pressure and also causing vasodilatation. The increasing blood pressure is mainly due to the vasoconstriction, and decrease in blood pressure is mainly due to the sympathetic vasodilator system. And when we speak about this short-term regulation, this is the important thing that we should know. That is the Baro receptor reflex, because this is the reflex which is going to get activated within seconds. So the Baro receptors, they are the pressure receptors or the pressure sensors which is present in the carotid sinus and in the arch of aorta. You can see here, This is called, this is the common carotid artery. And the internal carotid artery, you can see a dilatation. This is called as a carotid sinus. And you would have seen in the respiratory system, you have the carotid body and the aortic body. Aortic body is present close to the arch of aorta, and the carotid body is present close to the bifurcation of the common carotid artery. So these two are the chemoreceptors, whereas the carotid sinus and the aortic sinus, arch of aorta actually it also is a receptor. Arch of aorta contains receptor. The cell itself acts as a receptor. The carotid sinus, the dilatation present, it has a receptor called as a baroreceptors, and the nerve fiber which is coming from the carotid sinus is the 9th nerve, and the nerve fiber which comes from the aorta, which receives signals from the aorta, is the 10th nerve. So glossopharyngeal nerve carries information from the carotid sinus, and the aorta and the vagus nerve carries information from the aorta. So these two nerves, glossopharyngeal nerve, that is the 9th cranial nerve, and the vagus nerve, the 10th cranial nerve, these two nerves prevent the alteration in the blood pressure. Hence, they are called as buffer nerves. So glossopharyngeal nerve and the vagus nerve, they are called as a buffer nerves because they prevent the increase in the blood pressure or decrease in the blood pressure. So the main receptor is the carotid sinus and the aortic sinus. You have the receptors called as baroreceptor. They are actually the stretch receptors. They are sensitive to the changes of the stretch. When the blood pressure is more, the carotid sinus stretches. Thereby, the glossopharyngeal nerve detects a stretch of the carotid sinus and sends information to the brain saying that there is increase in the blood pressure. Or if when the aorta is stretched due to the increase in the blood pressure, the information is taken via the vagus nerve to the brain. And if there is shrinkage or if there is a decrease in the stretch, and that also will be sensed by these receptors, stating that there is a decrease in the blood pressure. This is the flow chart to say how the baroreceptor acts. With the increase in the blood pressure, you can see the stretch of the carotid sinus. The carotid sinus is stretched. And also the aortic sinus. And this discharge is detected by the 9th and the 10th cranial nerve. This stretch is detected by the glossopharyngeal and the vagus nerve, and they stimulate the nucleus of tractus solitarius, which is present in the medulla, that is the cardio inhibitory center. Thereby it activates the vagus nerve and decreases the heart rate, and thereby decreases the cardiac output and decreases the blood pressure. The other pathway is it inhibits the vasomotor center. When the vasomotor center is inhibited, the sympathetic outflow is inhibited. Thereby, the decrease in the myocardial contractility and vasodilatation due to the sympathetic withdrawal, and thereby it decreases the blood pressure. So the increase in blood pressure is brought back to normal. So when again, to summarize, increase in blood pressure, when the blood pressure is increased or when there is a fluid overload, it is going to stretch the walls of the carotid sinus and the arch of aorta. And these two are the sensory nerve ending of sensory fibers are present here. That is the vagus nerve, sensory fibers of the vagus and sensory fibers of the glossopharyngeals are terminated here, and they carry the signals from these two receptors, and they send information to the nucleus of tractus solitarius, and thereby causing inhibition of the vasomotor center and activation of the vagus nerve. And vagus nerve activation puts a brake to the heart, thereby decreases the cardiac output and decreases the blood pressure. Whereas inhibition of the vasomotor center causes decrease in the myocardial contractility and causes vasodilatation. So alternatively, if you see the decrease in blood pressure, when the blood pressure is decreased, what will happen? There is less stretch to the carotid sinus. Carotid sinus is stretched less. There is less stretch. So decrease in the discharge of 9th and the 10th cranial nerve. So if you can see here in this picture, there is Increase in blood pressure, increased discharge in the 9th and 10th cranial nerve. Here you can see the decreased blood pressure, there is decrease in the discharge of the 9th and 10th cranial nerve. So the nucleus of tractus solitarius, that is a cardio-inhibitory center, is less activated. Thereby, inhibition of the vagus nerve, because the brake is lost, thereby it increases the heart rate, which increases the cardiac output and increases the blood pressure. Similarly, disinhibition of the vasomotor center, that is activation of the vasomotor center. So stimulation of the sympathetic outflow, thereby it increases the myocardial contractility and vasoconstriction. So this is the mechanism how the Baro receptor acts. And this Baro receptor is mainly for short-term regulation and not for long-term regulation. The reason behind this, these Baro receptors are adaptable. So when there is increase in blood pressure for a prolonged time, they get adapted to the high blood pressure. So they are not useful for long-term regulation of blood pressure. And also these Baro receptors are activated in the pressure range of 50 to 200 millimeters of mercury. So when the blood pressure is below 50 mm of Hg, Baro receptor will not work. When the blood pressure is more than 200 millimeters of mercury, this Baro receptor reflex regulation will not work. The range is 50 to 200 millimeters of mercury. And the other mechanism is for short-term regulation is a chemoreceptor reflex. But this chemoreceptor reflex is mainly concerned with regulation of respiration rather than regulation of blood pressure. Because these chemoreceptor, that is a carotid body and aortic body, they actually detect the concentration of oxygen or chemical substance in the blood. So they have the less job to do with the regulation of blood pressure, but instead, if they also send signals to the cardio inhibitory center and vasomotor center. When the vasomotor center is activated, it causes vasoconstriction, thereby increases the BP, and if the cardio inhibitory center is activated, it causes bradycardia. So, but the role of this chemoreceptor is negligible. The major role is played by the baroreceptor mechanism. And the most important short-term regulatory mechanism is the Cushing reflex or CNS ischemic response. It is also called as last ditch response. So it is called as last ditch response. So even if the blood pressure is decreased less than 50, so when the blood pressure is reaching about, when there is a hemorrhage of blood, sudden blood loss is there, the BP is decreasing. So the main power of this CNS ischemic response is it can increase the blood pressure from 20 millimeter of mercury to 200 millimeter of mercury and can maintain this for at least 15 to 20 minutes. That is the importance of this Cushing reflex. Keep in mind that it can increase the blood pressure from 20 millimeter of mercury to 200 millimeter of mercury and can maintain this pressure for about 15 to 20 minutes. Hence, it is called as the last ditch response. Just imagine the blood pressure is increasing from 20 to 200. So if you see any patient lying in the road unconsciously, you can immediately take him to the hospital and he can be saved. You see here, gross hypotension, Cushing reflex. So Cushing reflex is also a form of CNS ischemic response. Here what actually happens is when the intracranial pressure is increased. Assume that the BP is normal, blood pressure is normal. Only when the ICP stands for intracranial pressure. When the intracranial pressure is increased, it will compress the blood vessels of the brain. So thereby less blood flow to the brain. So the vasomotor center also receives less blood supply. So even though if the blood pressure is normal, and due to this increased intracranial pressure, there is less blood flow to the vasomotor center, and the vasomotor center thinks that the individual is suffering from hypoxia. And due to decreased blood supply, it also causes hypercapnia. And thereby the vasomotor center is strongly stimulated and causes vasoconstriction. And it activates the baroreceptor reflex and causes bradycardia. Next is the somatosympathetic reflex. So any pain sensation or during exercise, activation of the proprioceptors, it activates the vasomotor center and increases the blood pressure. And the atrial stretch reflex, you can see increase in the venous return. That is, if there is sudden infusion of blood or there is a volume overload, it causes atrial filling. Increase the blood volume increases the atrial filling. You have two types of receptors in the atria, type A receptor and the type B receptors. And activation of the type B receptors causes sympathetic inhibition. Thereby, it causes vasodilatation, it decreases the BP, but increases the heart rate. That's a Mary's law. And next one is the Bain bridge reflex. Infusion of saline or blood increases the venous return and it causes tachycardia. So infusion of fluid, and this is actually done in dogs, okay, to prove this reflex. So when there is a fluid overload, you can see there is a tachycardia, and this is called as a Bain bridge reflex. Increase in the blood volume or increase in the volume load, it causes tachycardia. And with this, we are completing the short-term regulation of the blood pressure. So is there any doubt in that? Short-term regulation, do you have any doubts? Sir, Kekda?
Yes, sir.
Yeah, okay. So if now I will proceed to the intermediate mechanism. So two intermediate mechanisms are there. That is a capillary fluid shift mechanism and the stress relaxation mechanism. So capillary fluid shift mechanism, as the name suggests, the fluid will be shifted to and fro from the capillaries. So if the blood volume is high or if the blood pressure is increased, the fluid from the blood vessels are shifted to the interstitial fluid. Thereby, it decreases the blood volume and thereby the blood pressure is decreased. So when the blood volume is more, and that leads to the increase in the blood pressure. Increase in blood volume causes increase in blood pressure. And this increase in blood pressure, what will happen is, it will think that the increase in blood pressure is due to the volume overload or increase in the blood volume. Thereby, the fluid from the capillaries are shifted to the tissue spaces, thereby decreasing the blood volume. And now if the blood pressure is very low or the blood volume is decreased, the blood flow from the interstitial fluids will enter into the, someone is writing. So when the blood volume is decreased, fluid from the interstitial space, they move into the blood vessels. So increase in blood pressure, the fluid moves from the capillaries into the tissue spaces. Decrease in the blood pressure, the fluid moves from the tissue spaces into the capillaries. Thereby, there is shifting of fluid between the capillaries and the interstitial space. Thereby, the blood volume is regulated. And stress relaxation is when there is an increase in the blood pressure. The blood vessels will go for relaxation, which is called as a stress relaxation.
Student, you just don't involve in the classes, or otherwise you exit from here. Don't disturb the classes.
Yes, someone is writing, sir. Yara write pannirukanga. Okay.
Don't write anything in the board, or otherwise you just leave from the classes. Don't disturb here.
You can
Sorry,
see
sir.
the name of the students that are writing. Alla varun sir, paathunga.
Yes, sir. நான் மார்க் பண்ணிக்கிறேன் சார். இருக்கு. Presentationல இருக்கு.
So stress relaxation, when the blood volume is decreased, the blood vessels go for constriction, thereby it decreases the blood pressure. When the blood pressure is increased, the blood vessel will go for dilatation, thereby the blood pressure is decreased. This is called as a stress relaxation phenomena. So depending upon the blood pressure, the blood vessels can go for dilatation or constriction. Then, so with that, we are completing the intermediate mechanism. And the last one is the long-term regulation of blood pressure. That is the renal mechanism. So kidney alone can maintain the long-term regulation of blood pressure. So if all the other system fails, then we have a kidney which can maintain the blood pressure. So one important thing is pressure diuresis and pressure natriuresis. When there is increase in the blood pressure or when there is a pressure overload, you can see pressure diuresis will occur. That is when we drink suddenly if you drink 1 or 2 liters of water, immediately you will be having increased micturition or increased urine output. This is called as a pressure diuresis. And also pressure natriuresis means increase in the blood volume, increases the excretion of sodium. So along with sodium, water is also gets excreted. And this is called as a pressure diuresis and pressure natriuresis. Increase in urine output is called as a diuresis, and increase in sodium or excretion in urine is called as a natriuresis. And this is the mechanism for long-term regulation. Decrease in the blood pressure stimulates the juxtaglomerular apparatus. The juxtaglomerular apparatus is present in the kidney. You call it as a JG apparatus, and that will secrete renin, and renin converts angiotensinogen into angiotensin 1. You can see here it converts angiotensinogen to angiotensin 1, and angiotensin 1 is converted into angiotensin 2 by the angiotensin converting enzyme, which is secreted by the lungs. And this angiotensin 2 is a potent vasoconstrictor. It causes vasoconstriction, thereby increases the blood pressure. So angiotensin 2 is also converted into angiotensin 3 and angiotensin 4, and these two, along with stimulation of the vasoconstriction, it also acts in the adrenal cortex to produce aldosterone. So aldosterone causes reabsorption of water and sodium conservation, and potassium excretion. So aldosterone increases the sodium reabsorption along with water, thereby it increases the ECF volume and increases the blood volume. So this is the mechanism by which decrease in the blood pressure is normalized by the kidneys. So to summarize, decrease in the blood pressure stimulates the JG apparatus, juxtaglomerular apparatus, which secretes renin, and renin converts angiotensinogen to angiotensin 1, and this gets converted into angiotensin 2 by the presence of angiotensin converting enzyme, and angiotensin 2 is converted into angiotensin 3 by angiotensinases, and they cause vasoconstriction, thereby increase in blood pressure, and also they stimulate the adrenal cortex to produce aldosterone, which is an important essential endocrine gland, that is adrenal cortex, and the essential endocrine hormone is aldosterone and the parathormone. So aldosterone, it causes reabsorption of water and sodium, and thereby it increases the ECF volume and increases the blood volume. Along with that, angiotensin also stimulates thirst. Thereby you increase in water intake, thereby you will have the increase in the blood volume and increase in the blood pressure. The other hormone is the antidiuretic hormone, ADH. which is secreted from the posterior pituitary. So when the blood volume is decreased, antidiuretic hormone is secreted from the posterior pituitary, and this ADH increases the water reabsorption. So you can recall while you are studying about the mechanism of urine formation in kidney, the formation of concentrated urine is mainly due to the presence of this ADH. If ADH is there, concentrated urine will be excreted. If ADH is not there, dilute urine will be excreted. So ADH increases the water reabsorption, and thereby it increases the blood volume and the blood pressure, and it also causes vasoconstriction, thereby increases the blood pressure. And the other hormone is ANP, atrial natriuretic peptide. ANP stands for atrial natriuretic peptide. It is secreted from the atria of the heart in response to increase in the blood volume. When the venous return is increased, ANP is secreted. This ANP causes natriuresis and diuresis. That is increase in the urine output and increase in the sodium excretion, and thereby decreases the blood pressure. With this, we are completing the regulation of short-term, intermediate, and long-term regulation of blood pressure. Our final topic is hypertension. Sustained elevation of blood pressure, you call it as a hypertension. So as per the report of Joint National Committee, systolic blood pressure of less than 120 is considered normal, and diastolic pressure of less than 80 is considered as normal. 120 to 139 of systolic is comes under pre-hypertension, and diastolic of 80 to 89 comes under pre-hypertension, and 140 to 115 is stage 1 hypertension, and diastolic of 90 to 99 is stage 1, and 160 or more, 100 or more is called as a stage 2 hypertension. So hypertension is called as a silent killer. So types of hypertension, you have the essential hypertension and the secondary hypertension. Essential hypertension is called as a primary hypertension, like hereditary. The father and mother are hypertension, the 50% chance that the child can be hypertensive. Age, as the age progresses, blood pressure increases. In an older age, the systolic will be more than 140. Gender, female, the BP is less, male, it is slightly higher. Smoking increases the blood pressure. Obesity increases the blood pressure. Hyperlipidemia increases the blood pressure. Sedentary lifestyle and more salt intake and alcohol also increases the blood pressure. And secondary is due to the underlying causes like renal disease or any endocrine hypertensions like glomerulonephritis, pyelonephritis, polycystic renal disease, and renin secreting tumors, and stenosis of the renal artery, and endocardial hypertension, that is increase in aldosterone secretion, tumor of the adrenal glands, acromegaly, myxedema. So these are endocrine hypertension. These are the secondary hypertensions. Any problem in the central nervous system, you call it as a neurogenic hypertension. So miscellaneous form of hypertension you call as a pill hypertension, that is oral contraceptives. They cause sodium and water retention. So the individuals using oral contraceptives will be mildly edematous. It is due to the sodium and water retention. In pregnancy, also there will be hypertension is seen. It is due to the parasympathetics that is secreted by the placenta. What are the effects of hypertension on heart? It increases the workload of the heart. There will be left ventricular hypertrophy will be there, and persistence or prolonged hypertension causes angina pectoralis and ischemic heart disease. On blood vessels, it causes stiffening. On central nervous system, there will be microaneurysm or stroke. It can also lead to stroke. And in kidney, atherosclerosis in the afferent and efferent arteriole will affect the glomerular filtration rate and the tubular functions. And that's the end. Sir?
Sorry, sir.
Yeah.
Students, any other doubts? You can post your questions in a chat box.
Students are restless நினைக்கிறேன் 4 மணிக்கு 3 மணிக்கு வெச்ச உடனே they are restless.
Yes, sir. Post session will always be like that, sir, sometimes. Any doubts? No. Yeah, thank you. Thank you, sir. Thank you so much for your valuable time that you are spending with us. And thank you for accepting our invitations kindly in a short period of time, and thanking for spending your valuable time. And your presentation is very good, sir, elaborated, and especially the applied aspects, sir. It's very good, sir, explanatory. Thank you so much, sir.
But I want thank you very much, sir, for giving me this opportunity.
Yes,
so
sir.
The reason for me to present here is Dr. Purushothaman.
Thank you, sir. Thank you so much, sir. Definitely, we are expecting you to come to us directly, sir, in a future presentation, sir.
Yeah, thank you very much, sir. Thank you. Sir.
Thank you so much, sir. Thank you, sir. And we came to the end of the sessions. The feedback form will be forwarded to you to your mail ID. After filling the feedback, your certificate will be forwarded to your respective mail IDs. Is there any doubts? You can forward to your chat box, and even you can mail to us. Okay. And the final section, vote of thanks.
As per the lined-up schedule, we are on verge on concluding the program by thanking each and everyone who were the part of this event, and our marked up thanks to the chairman, dean, principal, head of the department, and the management who supported us to mark up this event as a remarkable one. And also a special thanks to our reputed guests who hailed us with the power of their knowledge. Undoubtedly, they showered us with the knowledge that we are very much aware of now. Hope we could once again get this implicit opportunity. Thank you all. Thank you all.
This session will be definitely helpful to our students, especially exam-going students, and insight for the newly joined students. Okay, and I would like to thank our students for helping me in this CD program run successfully. Thank you for both Famida and Sarika for being with us, and thank you so much. You can exit now.